Thank you. MiHIN. MiHIN is Michigan's nonprofit statewide designated entity for the exchange of information, healthcare information, legally, securely, privately. We are an unbiased data trustee. We sit in the middle of very powerful partners, very powerful sectors to create a ecosystem, to create a shared digital infrastructure through which data and information can flow in order to help transform healthcare, help to create more healthy Michiganders, help create more patient-centered personalized care. And we convene out with our stakeholders in ways like this. We are constantly, spinning up work groups under our Operations Advisory Council. We work very closely with our hospitals and our health systems and our state government and our payers. And we want to work with every single one of you that's here today. Next slide. MiHIN is the interoperability layer, the infrastructure between different tiers of our ecosystem, right? We provide the foundational framework technology that enables tools to function. And we sit, like I said, we sit as this layer, this utility between payers and between health systems and hospitals and their provider organizations and CMHs and FQHCs. And we're all working on behalf of to support our doctors, our nurses, our clinicians, our community health workers, really like our human beings, those who are seeking care. Next slide. Thanks. So just to give you a quick background for today, in response to the critical and complex interactions between medical, behavioral, social, and economic factors in maintaining and improving health, and the recognitions by our stakeholders that human beings move between organizations and their source systems as they receive care, MiHIN began planning to support enhanced collection of social care data and improve cross-sector data exchange in 2016. The term social determinants of health is widely used in healthcare, and it's often misused to describe efforts to fix the non-medical factors that affect people's health. Many in the healthcare industry use SDOH as if it means the same as other similar health ideas, and it can create confusion. Public health experts use the term differently, leading to misunderstandings when trying to discuss ways to improve population health or reduce those core inequalities. There's just a mix-up of words, and MiHIN really wanted to focus in on developing an approach for cross-sector data exchange that supports several directed use cases to reduce health disparities between health and social care, with clinical community linkages to support educational support with child school-based services, the correctional system and re-entry, integrated behavioral healthcare services, as well as statewide support programs for major social problem domains, notably housing, food, and transportation. So social determinants of health impact everyone. They're not something that an individual can have or not have, and they're not positive or negative. Too often, SDOH, the concept is framed with like a solely negative connotation. But for the purposes of advancing health equity, it's essential to remember that there are social factors that confer health benefits to certain populations and simultaneously cause harm in others. For purposes of this discussion, we're going to look at health equity as the goal. The ultimate vision is a country, a world, where disparities no longer exist because everyone has access to the resources they need for optimal health. Health disparities are the challenges. The disparities highlight the current state of inequality, and provide evidence-based for health equity initiatives. Health equity can be categorized as an active state, the action to ensure that all population groups living within a certain area have access to the resources that promote and protect their ability to thrive. And you'll see, I took this, are we on the same, are we looking at the same thing here? Let me just make sure. Yes, you'll see here, I took this from the Paving the Road to Health Equity put out by the CDC just in June of 2024. And I quite like it. I like seeing the infrastructure as, the supports to the appropriate programs, to the appropriate measurements and the appropriate policies to achieve, this major goal. Let's see, next slide, please. I am wanting to now distinguish between social risks and social needs, because the difference emphasizes the patient's role in identifying and prioritizing social interventions. This concept is at the heart of efforts to implement shared decision-making in medical and healthcare. The idea follows an understanding of what matters in the context of a patient's life, combined with clinical expertise, and it's needed to make the most high-quality decisions about the right course of treatment for a patient. A tool may uncover multiple social risks, such as food, housing, and utilities instability. But in the end, a patient may tell her provider that her most pressing social need is finding a safe place to stay away from a violent partner, right? So as MiHIN continues to provide interoperable infrastructure as a foundation, tools will provide the functionality, and trust will drive the interventions. All together, we're hoping to certainly drive efficiency and innovation. But one of the things that I found most interesting when I was working at a community-based organization in Washtenaw County was when people were being screened for social needs. They often screened positive for a social need. And when asked by a doctor if they needed help, they told the doctor they didn't need help. And to me, what they were saying was they didn't need his help. Because when we similarly screened and assessed our clients in the community, and when we asked if they wanted our help, the answer was yes. Today, I am really excited to share with you all our new partner, Socially Determined, which is a tool unmatched for its intelligence on social risk. Social Determined's proprietary risk models incorporate thousands of raw and publicly available data elements for federal, state, local, commercial, and consumer from local, federal, state, commercial, and consumer data resources. We at MiHIN believe in the power of combining our active care relationship services, our clinical data flows like ADT, with the social risk analysis offered by a tool like Socially Determined to align organizational goals with actionable intervention strategies. I am going to pass the baton now to Eli and to Chris. Eli, Chris, welcome. I often tell our audiences to please engage. I'm looking for your chats. I am looking for your questions. Kate, I don't know if people can come off mute right now, but we will have time for a question and answer. Please take it over.
Thanks, Joanne, and good morning, everybody. Just quickly by way of introduction, my name's Eli Brick. I'm a vice president here at Socially Determined, a company focused, as Joanne mentioned, on social determinants of health, risk data, and analytics. I lead our partnership efforts with payers and providers, and I'm joined this morning by my partner, teammate, Chris Talley. Chris, do you want to give a quick intro, and then I'll share my screen and we can get into the presentation?
Sounds good. Thanks, Eli. Good morning, everyone. Chris Talley, Senior Director of Customer Success at Socially Determined. So you can think of me as an extension of the teams and clients that we work with, focusing on use case development for different social risk initiatives across the myriad of organizations that we work with. So again, pleasure meeting you all today, and back to you, Eli.
Awesome. So we'll go ahead and just give a brief overview of who we are at Socially Determined, the work in partnership with MiHIN. We've been working together now for the better part of a year to figure out and try and enable partners, members of the HIEs across the Health Information Network across the state of Michigan to access more granular, more actionable data more proactively when it comes to understanding social need within a population and the communities that you all are focused on serving. I'm going to walk through just a couple of slides, and I'll ask if folks can
We can see it.
excellent. And I am going to present. Am I full screen now, Joanne?
You betcha.
Excellent. Awesome. So just to quickly ground folks in who we are as an organization at Socially Determined and the partnership with MiHIN. This data may be familiar, these numbers, to folks on this call, but if not, they're usually a great place for us to sort of orient the conversation and introduce this concept of leveraging data to better understand in a more proactive way what's going on from a social needs perspective within a population of patients, members, people, and the communities in which they live. On the left-hand side of the screen, that number 63 minutes is the amount of time per year the average adult in the United States spends under the care in the outpatient center of a physician, nurse practitioner, or PA in a given calendar year. That's 63 minutes then as a patient, which leaves 525,537 minutes as a person, right? Experiencing our lives outside of the clinical care setting. I tangent, but had the pleasure of seeing Wicked in theaters over the weekend. Oftentimes when we flash these numbers, if anybody has any musical theater exposure, we get questions, comments, reaction related to Rent, Seasons of Love. But key theme here, 63 minutes as a patient, 525,000 plus as a person. And oftentimes, as all of us, many of us know from working in this industry, we make decisions and understand and derive knowledge about the folks we're serving largely from information that's either provided at the point of care in those 63 minutes or delivered, shared, seen, viewed in historical or retroactive data through claims. So our focus as an organization at Socially Determined has been to leverage the wide world of information and data that's out there on people and the places in which they live to start to characterize, measure, and quantify and give, again, this more proactive insight into what may be going on and impacting outcomes and care from those, everything essentially outside of the 63 minutes in that outpatient setting. See if I can get my slide to change. There we go. Oop. The focus, obviously, of this conversation and the emphasis in large part here is on equity. I won't go through every single piece of data on this slide, but certainly we can share this information and follow up. Social barriers, social risk is a pervasive challenge across the industry, as I think we all know, with really severe, meaningful, and profound impacts. The fact that we don't have information about what's going on outside of the clinical setting opens the door to not fully understand and be able to address, consider, and strategize around the barriers and risks that are facing populations. So as I mentioned, we at Socially Determined are focusing on partnering with healthcare organizations, groups like MiHIN, to enable their members, partners, organizations all across the state and all across the country with better insights to more proactively enable community investments, identification of strategic programs, partners, vendors to work with to, again, ultimately drive better outcomes, better care. We're a company that's been around about 7-8 years. Most of our clients, just to orient folks to the work that we do, are health insurance companies, providers, many folks who are moving towards or focused on participation in value-based arrangements or value-based care programs. The company's high trust certified, HIPAA compliant. And essentially, again, what we've done, and I'll explain this in more detail on the following slide, and ultimately here we'll show you our platform so folks can get a better understanding of what this actually looks like in practice. We're leveraging data from a really immense wide array of sources. If I can orient folks to this slide, there's a lot going on. If we start on the far left, what our organization does is pulls in data, raw data from a number of different sources and data elements, really three broad categories of information that we're using to build these curated analytics that look at social risk, both in communities and at an identified person and individual level. Those three data sources and sets are federal, state, local data. So that's publicly available data from sources like the American Community Survey, so census data, data from the CDC, HUD, FDA, USDA, Department of Homeland Security, HRSA. It's probably about 40 to 45 different publicly available data sets and sources we tap into. Those are wonderful data assets. They're available publicly at no cost. However, the challenge with taking that information and deriving insight out of it for use in healthcare and thinking about programs, partnerships, delivering the most appropriate, most effective care and serving individuals' needs. That data typically refreshes at different cadences. It provides insight at different levels of scale. So we have a data science research team and engineering teams who've normalized that public data, turned it into this useful insight in the context of social risk. Along with public data, we've purchased commercial business data for every business across the United States. That data is really meaningful and important to understand resources and access to resources within communities and for individuals within those communities. So think about commercial data being the location of every clinic, FQHC, hospital, pharmacy nationwide, and certainly across the state of Michigan. But outside of that clinical resources domain, we're also looking at information around location for every full service grocery store, fast food restaurant, different types of transportation assets and resources, schools, community centers, food banks. Really meaningful when it comes to understanding what is available and how local or what does access look like, again, for that community or people in a community. And then lastly, and really important, we also purchase consumer data. So that's commercially available data, identified individual person level, legal, marketing, financial data, which enables us to build these analytic models and these risk scores, which I'll again show in a second, practically in our platform, that don't look at social risk or think about risk in a single sort of rolled up risk score type of way, maybe how folks would be familiar to an HCC, but rather we're building these analytic models around all of this data, thousands of data elements that surface risk insights at the level of a social determinant of health domain. So you can see on the right-hand side, on the community level, we focus on 7 different categories of social need: economics, food, housing, transportation, health literacy. We look at the digital landscape and social connectedness. At an individual identified level, we're focusing on financial strain, food insecurity, housing instability, transportation barriers, and health literacy challenges. Important to the way that we think about the business we do and the way we've designed these models, we focus the domain level because that's oftentimes where a particular type of intervention or program or connecting a patient or member with a service to address that need is most impactful. And we'll show this in a second, but for every single one of these SDOH domains, community and individual, we've built our models to prioritize and identify risk drivers within each category. That's really critical in terms of a data framework and approach, because the way that you might think about serving the needs of an individual who's food insecure and whose food insecurity is primarily driven by lack of access is going to be a fundamentally different type of intervention and support than someone who's struggling with affordability as their main driver of their food risk. Before I click to the next slide, let me just pause there. Chris, anything that you'd like to add for the folks online?
No, I was going to hammer in on the drivers as well, but nothing else to add.
Excellent. And so I want to be clear, when we think about our relationship and partnership with an organization like MiHIN, one of the real opportunities when folks in the healthcare industry are enabled with more proactive data on what's going on again in the communities they serve, or for the actual individuals impaneled to their organizations or members of theirs on the health insurance side, the ability to bring this social risk data, again, derived intentionally and primarily from non-healthcare sources, into the conversation or the view and understanding of risk within a population, so that med, econ, and clinical risk, along with social risk, is where we really start to make a significant impact and be able to address and think about the needs of populations and how to best serve those needs in a much more, again, proactive, strategic, and thoughtful way. I'm going to go quickly here so we can actually jump into our platform, and you all can see what this tool looks like. A couple of different ways that we're surfacing and helping visualize data within our platform, which is what I'll show. The first is at a very granular community level, so being able to focus on and drill down to risk in those different domain categories, not at a zip code level, a county, or a census tract level, but all the way down to essentially a 200-meter block, and we'll show what that looks like. Because we have data on places and resources, that business data I referenced in the prior slide, we can help folks visualize where are different types of resources and assets relative to their membership or their patient population and social risk on the ground very locally within their communities. I'll make sure we touch on that. And then lastly, and really importantly, when it comes to thinking about population health, the ability to have identified person level information ahead of and alongside all the efforts that I'm sure many of you are going through to capture data from screening or surveys or Z codes within your EMR, this proactive ability to share a patient roster and receive data back, identified data back on the folks for whom you're focused on providing care. Again, enables the opportunity to understand risk in a much broader way at scale, but also at a level of precision to a person, and link that information and data up with the more sort of standard and common risk stratification prioritization efforts that are ongoing based on knowledge we have from the clinical setting or through claims data that we receive retroactively. I am going to stop my share real quick. While I'm doing that, Chris, Joanne, any comments or questions, Joanne, from you?
I just lost sound from you for a second. I just want to say, wow. There is what stands out to me is just how many data sets are available and can be purchased or can be curated to create this picture. How any one human being moves around this universe digitally. You know, we're really paying attention to things like data exhaust and really paying attention here at MiHIN to things like patient consent. So I am really, I can't wait to jump in and see this. And I want us to focus back at the end on what it means, you know, to have data that is protected and coded and standardized through the HIE, and what it means to have, you know, access to this data. So thank you. Let's keep going. Also, I don't see anything in the chat. That makes me sad. I'm looking at Q&A, like where you have to type it in, and we'll get to it at the end.
Yeah, so keep those questions coming, please, folks. Joanne, are you and everybody seeing my screen again?
Yes, sir.
Excellent. So what I'm going to demonstrate here is the socially determined platform. It's a tool called Socialscape. An important note, many, and in fact, all of our clients, our partners at Socially Determined have access to and have team members who are logging in and leveraging this tool and looking at the data within the visual platform you'll see here. It is important to note as well, though, that all the data that we provide can also be delivered and is standardly delivered to our clients as an outbound file or feed. That's relevant in the context of, again, thinking about how do you integrate this social risk data with data that's already available from a claims perspective, a pop health analytics perspective. We've seen folks integrate some of this information into care management platforms, their enterprise data warehouse, lots of opportunity for data integration. But for the demonstration here, we'll be walking through the information within this tool, Socialscape. So just to orient folks to the platform, there are a few different ways that we make data viewable and available. And as you know, hopefully you'll see and agree, we've spent a lot of time thinking really hard about what effectively we're doing here is bringing a data set to healthcare organizations that they may not have had access to or is not native to healthcare. So the emphasis we've put into the combination of visualizing this information in the way that's most streamlined, straightforward, and usable, actionable is one key takeaway. I won't have time to spend a lot of energy on it here, or excuse me, a lot of time on it here. We've also spent a lot of time building up this knowledge base, which gives all sorts of definitions and clarity around what exactly we mean by different SDOH domains, what data is feeding the risk algorithms we're providing. So we try to make that context as readily available to partners of ours as we possibly can. I'm going to start over on the individual side in a platform or part of the tool that we refer to as individual risk baseline. We're going to focus on a demo population here. So these aren't, there's no PHI actually being shared, but what this part of the demonstration is representative of is a patient population attributed to any of your organizations. Again, no actual PHI, but in this case, there's a population of roughly 237,000 unique individuals. The way the collaboration works with our partners, they provide to us essentially a roster file. Folks on this call are no stranger to the acres format, obviously, in data exchange. With MiHIN, all we require or ask for in order to provide the data back I'm about to show is very basic demographic information on your patient or member panel. Things like first name, last name, gender, date of birth, and an address. So for the sake of the example, these 237,000 individuals would be part of a single client member or patient roster delivered to socially determined. We're then taking that demographic information from your attributed patient population and matching your population up with the roughly 260 million individual person level risk profiles we've already built and curated around all this disparate data that's available on a community level publicly, right? And that places data, what your resources look like local to the people in your population. But we're also using that identified consumer data here at the individual level to produce back and share back this insight that you're seeing on the screen in front of you now, which breaks down this 237,000 person population and identifies who within this cohort are facing elevated risk across each of these different 5 SDOH domains. So as you think about trying a number of different use cases for this kind of intelligence, but suppose that there was some sort of program benefit or thought around, say, for a specific cohort of patients, maybe our diabetics or folks with hypertension or a maternal health cohort, being able to quickly understand who within that group of individuals is most likely to be facing elevated food insecurity risk. We mentioned, Chris and I both touched on the fact that in these risk models, we're also prioritizing and identifying primary drivers of risk. So maybe we want to focus on individuals who are food insecure, whose food risk is primarily driven by access. To give a flavor for how we're coming up with that kind of insight, that's looking at a number of different data elements from an access perspective. However, we're talking about what is the density of healthy food options local to these people, these individuals. So within their communities, are there nutritional food options? What does the food landscape look like generally, the ratio of healthy and unhealthy, just to give a sense of how we're coming up with this insight. So you might think about food access, food insecurity, access to the primary driver, who may also be struggling with or dealing with significant transportation barriers and face significant health literacy risk. This idea of overlapping, co-occurring social needs is really key to how folks think about really understanding what's going on in their population and matching up needs and risk with available solution services that may already be in place. Oftentimes that's where folks start. And then we're also helping inform the strategy for where should additional investment be made in community partnerships, in supplemental benefits if folks are managing, controlling, and have benefit design as part of their mandate and the way they serve their patients, their membership. So now, rather than those 240,000 almost people in Michigan, we're looking at this much more concise list of 4,543 individuals. And every single one of those people is going to be listed below And we're going to be able to look at the individual level risk and contextual information on a person by person basis. So if we click on, an individual, we're able to get down to this individual level spotlight. What you're seeing here is some basic demographic information for this particular individual, but then you can start to see this person's SDOH risk exposure across the 5 domains. These numbers, 5, 5, 3, 4, 4, that's the risk score for the individual. We score on a 1 through 5 basis, 5 being severe risk, 1 being little to no risk in this particular category of need. Our risk scoring is relative, meaning it's relative to the population that you are responsible for, that cohort of individuals you provide to socially determined. That's a meaningful point for folks who may be serving a population that's by definition vulnerable from an SDOH perspective. We work with plenty of managed Medicaid organizations, for example, and Medicaid providers. So there's a sort of an inherent level of risk just based on eligibility. We want to make sure that we're helping prioritize and steer towards the folks with the greatest needs, even within a population or cohort that's already at elevated risk relative to the national population. So you're seeing a risk score 1 through 5. You're seeing a call out and shading, highlighting here for the risk drivers across each of the domains here. And then we also deliver just an immense amount of contextual data at an identified person level below these risk scores. Things like this measure of discretionary income, that's gross income per person after housing. Things like percent of the federal poverty level, potential SNAP eligibility. If the person was living in either a food desert or food swamp, we'd be able to tag and identify that and surface that information here. We know if folks rent or own their homes, have they had multiple address changes? So a measure of transiency in the prior couple of years. We have data on car ownership, vehicle ownership, which is certainly one component of a contributor to understanding someone's transportation barrier or transportation risk, as well as health resource scarcity. That example, it's showing neither. But this is where we're also identifying if folks are located in a provider or pharmacy desert. Again, that's using the data, what resources and services are available, highly local to this particular person. The only other thing to call out on this individual level risk view and risk profile, you'll see this button down here that says community programs. Folks may be working with or partnered with or familiar with an organization called Find Help, which was previously on Bertha's. It's an organization that focuses on building referral pathways and a resource directory for community-based organizations. We have a link built into this portal and platform. So if someone in your organization, say a social worker, CHW, care coordinator, was looking at an individual's risk profile here, identified them as high risk for food insecurity, and was planning on doing some level of engagement to confirm and validate that social risk with the patient, they could also, in the same platform or one click out of the platform, identify essentially this filtered list of food resources in that local community to think about what's the next best action, the right site of care or service to refer a person to address that social barrier. The last comment I'll make on the individual side before I turn it over to my colleague Chris to talk through some of our capabilities from a community risk perspective. It's common for clients of ours when they share their roster. So this list, if we go back just a couple clicks, of the 237,000, now the number showing 105 individuals in their population, they're also able to provide to us additional data and cohorting and segmentation. So if, for example, we wanted to just focus on social risk exposure for patients who maybe have a chronic kidney disease diagnosis or a diabetes diagnosis, or if we think about quality measures, maybe haven't seen a primary care physician in the prior 12 months, we can start to drill down and isolate based on that existing criteria of yours from again, a med-econ and a clinical perspective. And so just by way of example, now we're looking at SDOH risk exposure for folks who haven't had a PCP visit in the prior year within our population. And we can then go further and isolate for what are the social barriers that may be impacting folks who haven't accessed care in that case, or folks who have a specific chronic disease. As we think about, again, that matching up between social barriers and clinical risk. I am gonna jump over now to the community dashboards. And Chris, I'll turn the mic over to you, and we can work together to talk through some of the capability from a community risk exposure perspective.
Sounds good. Thanks, Eli. While you're pulling that up, just a couple other quick notes. We also have the ability, so Eli touched on some of the condition-specific information. We also have the ability to filter on other things like costs, utilization information. So for example, if you wanted to see all of your asthmatics with 4 or more ED visits that are at risk for housing quality issues, you'd be able to use that as a filter as well. So being able to identify additional data elements that might be beneficial to your specific use case. The other thing that we have the capability of doing is what we call benefits matching. So being able to empower clients to connect the dots between the what now and what's next. So we can curate, given our data sources and our algorithms, the ability to identify specific lists, force ranked by member that would be most at risk for things like patient transportation, food delivery, prescription delivery, asthma remediation, medically tailored meals, and tenancy sustaining services. We're continuing to build out those benefits matching capabilities. So if you've got a specific intervention partner or program or resource that you want to take full advantage of from a utilization perspective, we can help define, which population or which members would be most at risk or most in need of that sort of program or offering. All right, so you are now looking at what we call SocialScape Explorer. I would call this the most dynamic part of what we offer from a SocialScape perspective. This is where you're able to visualize demographic and social risk analytic information within communities of interest across the populations of the organizations that or the membership that you serve. So here you're seeing what Eli said, where you can see down to that 200-meter hexagon resolution. Across the top, we've got our risk domains. So just to sort of reiterate, economic climate, food, housing, transportation, health literacy, digital landscape, and social connectedness. We risk score on that scale of 1 to 5 for each of these domains. So when you click on economics, for example, you're going to see a different view than if you clicked on food. So the darker the color, the greater the risk. So you can see in the Detroit area, pockets of elevated risk down to that sub-zip code, sub-neighborhood level view, where you actually can see what the social risk profile is at a specific cross street. So again, as you toggle across those different buttons, you can get a really close look at the social risk profile of the communities that you're interested in, or of the communities where you have the highest count of your members. So everything that we're seeing here is community risk specific. You are now also able to leverage, there are 4 components along the left-hand side of the screen where you can overlay your members to see proximity of social risk for your members, as well as concentrations of members with high risk. And all of that is filterable. So if you wanted to isolate all of your members that are high risk for a specific domain or for a specific age range, it's all very flexible. So as you're thinking about use cases and opportunities to leverage this type of data for your organizations, can get really specific and granular. So here you're seeing a heat map of where the members are currently within the Detroit area, overlaid with the community risk of the neighborhoods that they live in. The other capability that you have here is not only to see proximity to people, but proximity to resources. So in SocialScape, you have a preloaded places data set. So it includes things like Eli's showing, healthy and unhealthy food options, pharmacies, drugstores. So we could click on CVS, for example, and you could see proximity of where your members are to where CVS pharmacies are. So identifying areas of opportunity for where you have resources or where you may lack resources based off of the membership, your membership and the needs of your membership. You're also able to toggle on different boundaries. So if you wanted to look at state and legislative districts, school districts, zip codes, et cetera, you have the ability to do that. And then the last button down there is the boundaries section, and this is a really dynamic, area data set. So we can, this area provides users with the option to further customize their visualization across different geographies of interest. Some organizations have gone beyond using people and places to look at things like plotting membership based on specific disease states like diabetes or conditions, being able to visualize prevalence of select populations of interest by enabling users to be more focused and tactical when tracking or intervening on groups or individuals who require additional resources. So one blanket statement, I always say if it's got a name and an address, we can overlay it. We've had organizations give us Department of Corrections facilities, pharmacies that they want to work with, their CBO networks, their intervention partners, their freestanding ED clinics. We are able to customize all of that within your instance of SocialScape, again, to see proximity of membership to resources along with the risk of the communities that they live in.
Awesome. Thanks, Chris. And I'm just looking at the time. Maybe Chris, do you want to just do a couple minutes talking about
yeah,
Community Spotlight?
Yep. So Community Spotlight is one of our newer applications here. We can, we're already in Philadelphia. So this is a really quick and easy way to aggregate community risk data. So we've been working, well, I personally have been working a lot with many Medicaid populations that are constantly going through RFPs for either new populations or to confirm the populations that they currently have. As a part of that, we get asked things like, we want to see the social risk profile of all of our rural counties or all of our rural zip codes versus all of our urban. So this is a really quick and easy way to do that. So very customizable. I'll keep it as short as possible. So let's say, for example, you had a bunch of zip codes that you wanted to aggregate and see what's the social risk profile of these 5 or 10 zip codes. You would be able to name it. So we could name it, Michigan or really anything that would qualify to what you're looking at. You can select a boundary type. So where do you want to aggregate the data? You can click multiple zip codes. And what you'll be able to do once you've selected the areas of interest is actually be able to isolate and aggregate all of the social risks for the areas that you're interested in. So now, and looking at those 1, 2, 3, 4, 5, 6 zip codes, you can see the demographic profile of those aggregated zip codes. And if you scroll down a little bit further, you'd actually start to see the social risk profile of what's going on in those specific areas. So again, if you were looking at a specific zip codes of interest, counties of interest, you can aggregate them by selecting this. All of this information is going to resonate with the community risk side of the house. And you'll also be able to export this really quickly and seamlessly if you needed to drop it into a PowerPoint presentation, an RFP response, or even just share for a presentation to say, hey, there's a risk here that we really have to mitigate, or we've got an area of our specific geography that we're responsible for that could really benefit from some specific intervention or program. So it went really quickly. We are also happy to answer questions after the fact, but want to make sure that we're giving everybody the opportunity to ask questions while we're live today.
Thank you. Just for the record, when I saw this thing, I mean, Eli, Chris, my head, I could not believe it. It's going to take a minute. Or months, but to process. So give yourself that space. There are some questions in the chat, guys. If I can just kind of say them out loud, we can work through them together. There's a Samantha Lewis, and Samantha, please feel free to join, saying that the numbers here in the risk domain seem much higher than the results that they received in their own data set for Flint and greater Genesee County. How do you see primary care organizations employing this type of data outside of application to annual community programming design? Samantha, if you want to, I mean, it's a pretty layered question. If you want to come on and get to it, but primary care, using this type of data and the way that you all sort of work with it, employing it for annual community programming design. Have you heard this about this annual community programming design?
Not so admittedly not if that's a specific
Yeah, I hadn't
program.
either.
So maybe if someone wants to come off and clarify, in terms, and I'll answer this at a relatively high level, but as Joanne said, this is meant to be an introduction, right? And so if folks have more detailed questions or want to connect with us directly or with the MiHIN team and socially determined, that's the point here, right? We want to have those follow-up conversations. Generally speaking, again, this idea of bringing patient level data into strategic planning and thinking about what are the types of partnerships, services, programs that need to be in place to address the needs of our membership and our population, our patients. That's where we're seeing that's sort of one lane of use of this data for a provider, for a practice, a primary care clinic, because we can look at both clinical risk or disease groups like diabetics. We keep using that example, but there's a lot of flexibility and customization there. Understanding for our folks, our diabetic population, or folks with prediabetes, what are some of the common characteristics from a social needs perspective, creates the opportunity to think differently about care planning and, again, partnership and resources that are local to the practice or the sets of practices to link folks up with services to address those social needs. I see there's a couple questions in here that are asking about, and maybe this was part of that one you just referenced, Joanne, data captured at the point of care through screening, through survey, through actual direct assessment with patients. I think we want to be really clear. This data set and this tool is by no means a replacement for the work that's being done at the point of care to collect data and information direct from patients. From a trust building perspective, certainly there's someone who's willing to open up about their social needs to their provider. That's not what we're doing here, right? Our focus is on bringing data at broad scale and at the precision of a person to help you think more proactively about what are the different types of barriers and for whom that exist within our population, so that you can be a little bit more proactive and strategic around, oh, it looks like, food insecurity with a particular driver is impacting a significant percentage of patients that are already being prioritized or maybe aren't being prioritized yet from a care management and engagement perspective. So just a little bit of texture on that. Chris, anything that you'd add just from your work with clients?
Yeah, I think there's also obvious clinical applications as well. So thinking about suboptimal utilization and mitigating risks. Also looking just at health plan optimization and benefit design. So is what you're offering to your members being leveraged? Is it important? Is it valuable? Should it be something else? So making sure that your members are getting the appropriate benefits based off of their needs. The other thing that I would sort of call out is looking at areas where maybe you are looking to grow your membership or increase membership in a specific geography and saying, I'm going to look at the community risk over here, and it looks like there's a lot of social risk from a food perspective, but we don't have any food banks or food programs in that area. Maybe we should start partnering with somebody there. So when we do, expand into this geography or county, we are already set up for success to aid in the membership and the growth there.
There's some really good questions. Raw data on individuals served be available for integration into your reports database. I think what's really important here, guys, is what they're saying is like, look at what we can do, right? There's data that we access, socially determined accesses and can access. And then there's the data and information that you care about. And where the sweet spot is sort of taking all of this, which is a lot, and putting it into a lens, into your lens. And I think that's what, that's really what we're trying to see. We're trying to see happen. Should note also that MiHIN is not sharing any network data with socially determined. nor, nor will we until you decide that your acres population or your ADTs, right, or your social needs screening population set should be integrated. I think the power is really this being able to integrate the data sets that you deem as your source of truth. There's this cool question about this chronological data, like historical risk. Can you?
Yeah. Yeah, I can feel that, and then tag on a little bit to the individual requests of both of Marianne's questions. So to Eli's point, when he was showing that individual spotlight with the social risk scores per domain at the individual level, so we have roughly 42 different data elements per person that will be the output. That you'd also be able to integrate in any data warehouses, if you have your own, BI tools or reporting tools that you want to integrate that type of data in. So again, things like whether they rent or own their car, all the risk scores, whether they own their home. So being able to leverage all those data elements at a person level. So yes, you would be able to have access to that data outside of the platform. We usually refresh that on about a monthly basis as people enter and leave plans. As far as the chronological data piece, so we have worked, coming from the customer success team, so we really partner with our clients as a part of this. So if there's specific interventions that you want to measure, to snag a baseline for, and then it typically can take a year or more to actually see the results of some of that work, but we have done that in the past. We're able to help sort of scope a baseline, be able to deploy an intervention with your all's help, and then be able to see, did utilization decline, for example, or whatever the use case may be. So while we don't track that in the platform from a chronological perspective, we have the ability to isolate specific data points at a specific place in time to help work with you all to deploy whatever that intervention is, and then be able to see if that actually had any impact to your population, based off of the duration at hand.
Howdy. I just want to let you know that one of the key issues that and the data that we often put out is, okay, year to year, how have we improved the care for our individuals served? And having that historical information, I mean, in some ways, if we can get the discrete data, we could actually create the tables ourselves in a database to track it historically from your perspective. And that might give us the information. Just, thinking outside the box. How can we use this? Because in behavioral health, being able to show that your programs have been effective is key. So thank you very much for your answers.
Of course.
There's one question I'm seeing from Jim. He's asking what and how we're querying to determine that a PCP visit did or did not occur, and then give a little more context on clinical care. So this is a key question. The data that's provided to us by our clients, the provider, the health plan, any organization, the HIE, right, is the answer to that question. So we're not plugging into or pulling data out of the EMR or ingesting data in an automated way like that. Rather, when our clients provide to us their list of folks for whom they want this individual level social determinant of health data, they also have the ability to provide in that, basically that roster file they share with us, these additional attributes. So they would need to know, here are the folks that we haven't seen a PCP visit for in the prior 12 months or the prior 6 months. They would tag those individuals in that roster file so that that cohort could then be filterable in the platform or through the social risk individual level data set we send back to them. And that's where, again, we're talking about this matching up of what we bring to the table, individual level social risk data, with the context and nuance and stratification and segmentation work that's already being done at the provider level or the plan level.
Melissa, in the question and answer portion, sort of I don't know if it's different or if anybody can see it, has 2 questions. Do you know how outcomes are improved using this tool over directly asking the patient? I think, Eli, you've said there is no, and I think you should hit it, asking somebody how you can help them or if they want your help is is the work. All of the ways in which you might contextualize your care with this person in front of you might be supplied by this tool. There is context, but we are still human, right? If anybody, I don't know if everybody here is, and we do have the ability to still to decide how we want to move forward in any one dynamic, any one relationship, any one care setting. So this is not meant to replace that at all. Right?
Right. That's accurate. And part of where we hear from our clients, this data is making the biggest impact for them. We still live in a world, unfortunately, where capture rates for SDOH screening or Z codes is very low relative to the entire population. That data that's collected by individuals is also highly dependent on them accessing care. So oftentimes we miss some of the folks who are most vulnerable or most in need of social determinants of health intervention programs and engagement. And oftentimes we see that the social barriers are actually a significant inhibitor to them coming and accessing care, right? So what we're trying to do is help bring insight more proactively so you can understand those dynamics and think strategically about the most appropriate ways to address some of those realities for the populations and communities in which you operate.
And then
I realize we're at time too.
Yeah, we're at time. Guys, this is just the beginning. Like I said, this was the big one, right? And we will follow up with any of you. We will have this on our website. We will follow up with specific deliverables in terms of like marketing artifacts and showing everybody what they can and what they can do, how to work with MiHIN and Socially Determined. And then later on, the beginning of next year, we're really going to start getting into those hows and what's flowing through our network that might be specific, how you might want to be working through active care relationship service with this tool. This is just the beginning. It's a big one. Thank you for coming, all 127 of you before Thanksgiving. I hope you learned something. I hope you got excited, and I hope you'll come back for more. Thanks, Eli. Thanks, Chris.
Thanks, everyone. Happy Thanksgiving.
Yep. Thank you.
Thank you so much.